During the first phase, treatment will focus on pregnant women, breastfeeding mothers and newly diagnosed patients. It's hoped the single tablet that replaces a multi-tablet regime will make compliance much easier. The Health Minister says systems have been put in place to ensure the drug is available at all times. With almost 2 million South Africans on ARVs, it's the biggest rollout in the world. More than 7,000 doctors and nurses have been trained to manage patients at 3,000 facilities countrywide. For more on the story, we welcome Health Minister Dr Aaron Motsoaledi to the studios. A very good evening to you. You've had a busy day, so thank you for joining us.
Good evening, Babakshnes. I'm very tired, actually.
I can imagine. Yes. Now, talking about this new single tablet dosage, it's said to be easier for patients to take, and it's also said to have less side effects. What are some of the other health benefits?
Well, it will be more efficient. Let's take, for instance, pregnant mothers who are on prevention of mother-to-child transmission, PMTCT. They are on dual therapy. On this fixed dose combination, it will be like a triple therapy, which means the viral load will fall much lower. We are actually expecting that transmission from mother to child will actually lower even more than what it is now.
Let's talk about why there's a delay, why you're doing this as a staggered process. So first you have priority patients being the breastfeeding mothers and the pregnant mothers and people on HIV treatment or ARV treatment rather for the first time. Why the staggered process to get everyone else on? Why that 2-month delay?
Well, firstly, switching over people is going to be a mammoth of a task. We have got close to 1.9 million people on ARVs. You can't just switch them over in one day. So what we decided to make it easier is to choose 3 groups of people. Firstly, the pregnant women who are on PMTCT. It's a specific group, we know the numbers. Secondly, the lactating mothers, those who are breastfeeding. Thirdly, those who are newly diagnosed. Instead of starting them on the old treatment and switch them over, we rather just immediately start them because now that is available. Then we'll do that for 3 months, try and check, see the problems, fine-tune the system. Only after June will then individual physicians decide when to switch over the patients who are already on ARVs. That means these are the thousands and hundreds and thousands of people who are already on ARVs. That decision is not going to lie with me. It's going to be an individual doctor who decides when to switch over to the new treatment. Only that they can't take that decision now. We're only allowing them to take it after June.
Now, you've just said it's a mammoth task, and that it is. How long then, in terms of a time frame, will it take to have everyone onto the new single-dose system?
I think it's going to depend more from doctors. From our side, we'll just provide. For instance, from today, we have got 390,000 doses distributed in 3,000 facilities around the country. We have now ordered 915,000 more doses. They'll start delivering them this very month of April. And suppliers have told us that by September, they'll be able to produce 1.5 million doses per month, which means as early as September, 1.5 million people can actually switch over, provided their doctors decide so. But I think practically it's going to be a little bit slower. As a doctor myself, I know what physicians are going to say. They're going to say, Babakshne, you've been on this treatment for 10 years, everything was fine, no problem. Why are we in a hurry to switch you over? So they'll sort of delay. In other words, it's going to be more of a clinical decision than just a logistical decision.
Now, the department has come under criticism in the past where clinics have run out of ARV treatment. What are we doing this time around that's different to ensure that doesn't happen? Well,
that's our weakness, for Babakshne. It's our weakness because we are still using the depot system, whereby drugs are ordered, suppliers go to put them in one depot in the province, then the depot must decide which facilities are getting it. That is our biggest weakness. You are aware that we have already taken a decision that we are going to do away with the depot system because it's problematic. There's a lot of corruption there. There's a lot of mismanagement. You know, all sorts of things are happening there. But now that they are there at the moment, we thought, because we have got to live with them for the time being, what we have decided is that once a month, we're going to have what you call a supply meeting, a monthly supply meeting where the Department of Health meets together with the suppliers. We discuss about the logistics. We project for the next 3 months how many doses are wanted, what will be the likely problems. And then on our part also as a government, every week we want the report from the individual depots from around the whole country to tell us exactly what's going on. We're going to continue that until we switch over to a situation where facilities are able to order directly from the suppliers.
Thank you very much. That was Health Minister Dr Aaron Motsoaledi talking to us about the latest ARV rollout.